Hello, welcome back. Let's continue our discussion on the cranial nerve. Before break, we discussed about the mandibular nerve. So basically, we're done with the trigeminal nerve. We're done with the trigeminal nerve. That means we are done with all the ganglions topographic connection. Now we know all the four ganglions to which nerve precisely they are topographically related to. Let's talk about the nerve, the two nerves which will complete all the ganglions functional connection as well. So let us talk about the facial nerve first, followed by the glossopharyngeal nerve. So there we go. This is the facial nerve. How exactly facial nerve is arising from, which nucleus it is arising from, what part of brainstem it is coming out from, that we'll all do it in the neuroanatomy part, that is tomorrow. Now first let me make a plot for this facial nerve. Now guys, let's say this is the brainstem here, whatever part may be. So facial nerve comes out from many nucleus in the brainstem, many nuclei in the brainstem. We'll talk about the columns of the facial nerve in a minute. The facial nerve, guys, facial nerve is having the longest intraosseous course. It is having a very long course inside the bone. It goes into internal auditory canal. It is related to the medial wall and posterior wall of middle ear cavity, and then it comes out of the stylomastoid foramen. So we said the longest intracranial course was the fourth nerve. The longest intradural is abducen, and this is the nerve with the longest intraosseous course. That is a nerve with a very long course inside the bone. Let's say this is the internal auditory canal. This is internal acoustic meatus or internal auditory canal, and there we have the middle ear cavity. And let's say this is parotid gland. Schematically, this is middle ear cavity, parotid gland is this internal auditory meatus or internal auditory canal. So just to keep it simple, we are not talking about the two, sensory division and the motor division of mandibular nerve, that is nervus intermedius, the sensory one. Let's say this facial nerve, this one component. We have facial nerve, where exactly it is going, what it is supplying, and what are its relations. Now facial nerve goes out of this, goes inside, I should say, from the internal auditory canal. It makes a very sharp bend related to the medial wall and posterior wall of the middle ear cavity, and it comes out through the foramen that is called a stylomastoid foramen. This bend here is called as the genu. What genu? This is internal or external? This is external genu. Internal genu is present within the pons when the facial nerve winds around the abducen nucleus and make facial colliculus. That is internal genu. This is external genu. So the nerve makes external genu and is related to two walls of the middle ear. I'm sure you read about this in the ENT as well. It is related to the medial wall of middle ear and to the posterior wall of middle ear before it comes out through this stylomastoid foramen. This is stylomastoid foramen. Okay, a branch of facial nerve from the region of this external genu, this is called as GPN, that is greater petrosal nerve. This is one more bothering topic for us in the head and neck, that is petrosal nerves, greater petrosal, lesser petrosal, deep petrosal. So this is greater petrosal nerve. Now what exactly is greater petrosal nerve? Guys, greater petrosal nerve, this is preganglionic parasympathetic nerve. It will go and relay in certain ganglion, and from that ganglion the postganglionic fiber will go to supply lacrimal gland. So that means it is still preganglionic. Do not compare it to the geniculate ganglion we have here. It's not coming out of the geniculate ganglion. Okay. Greater petrosal nerve is a preganglionic parasympathetic nerve. It's a parasympathetic nerve, so it will relay into the parasympathetic ganglion. So greater petrosal nerve is here. How does the sympathetic nerve reach their destination in the body? I mean, for the sympathetic nerve in the body, how do they reach their the target structure? They reach the target structure by making a plexus around blood vessels. Anterior wall of the middle ear cavity is related to the internal carotid artery. If this is internal carotid artery here, the nerve plexus which is present around the internal carotid artery, there is a sympathetic plexus present around this, and from this sympathetic plexus around the internal carotid artery we have a nerve which go and join the deep petrosal nerve, join the greater petrosal nerve. This is called as deep petrosal nerve. Greater petrosal nerve, I repeat again, greater petrosal nerve is preganglionic parasympathetic nerve. If you want to write down somewhere, please write it, because they even asked this question. They gave 4 options that greater petrosal nerve is preganglionic parasympathetic, postganglionic parasympathetic, preganglionic sympathetic, or postganglionic sympathetic. So it is a preganglionic parasympathetic nerve. We know we have 4 nerves which are parasympathetic, 3, 7, 9 and 10. It is coming out of the 7th nerve. It is a parasympathetic nerve and it is yet to relay into the ganglion, so it is a preganglionic parasympathetic nerve. Whereas the nerve which is coming out of the plexus around internal carotid artery from the sympathetic plexus, that is deep petrosal nerve. The question is, this deep petrosal nerve, it is sympathetic nerve, but is it preganglionic or postganglionic? Now all these sympathetic nerve that you see around the internal carotid artery, they are actually coming from superior cervical sympathetic ganglion. It is already coming from the ganglion, so it has to be the postganglionic. Greater petrosal nerve, preganglionic parasympathetic. Deep petrosal nerve is postganglionic sympathetic nerve. Preganglionic parasympathetic, postganglionic sympathetic nerve. Together they are called as nerve to pterygoid canal, or also called as Vidian's nerve. We call it Vidian's nerve or nerve to pterygoid canal. Greater petrosal nerve and deep petrosal nerve together, they are referred as Vidian's nerve or nerve to pterygoid canal. Greater petrosal nerve, we said it is preganglionic nerve. So obviously it has to go and relay in some ganglion. Guys, it will relay into this ganglion which we already know, and this is PPG, that is pterygopalatine ganglion. So pterygopalatine ganglion, preganglionic fiber to the pterygopalatine ganglion are coming from greater petrosal nerve, and we already know rest of the story. If you have to supply the lacrimal gland from the pterygopalatine ganglion, how will it go? From the pterygopalatine ganglion, what was the topographic nerve, guys? If you think back, we said that maxillary nerve, that connection over there, and then into the lacrimal gland. From the pterygopalatine ganglion, the topographic fibers will go into maxillary nerve. The maxillary nerve then gives off zygomatic nerve. Zygomatic nerve, you remember, it divides into zygomaticofacial and zygomaticotemporal. And this zygomaticotemporal nerve, it joins with the lacrimal nerve, which supply the lacrimal gland. That is how lacrimal gland is supplied. So postganglionic fiber from the pterygopalatine ganglion, following the same rule, the nerve which topographically connects the ganglion will carry postganglionic fiber. So topographic nerve is maxillary nerve, so postganglionic fiber, they go into maxillary. Which branch of maxillary? Zygomatic nerve, dividing into zygomaticotemporal and facial, into the zygomaticotemporal, which joins with the lacrimal, and lacrimal supplies the lacrimal gland. This is the secretomotor supply to the lacrimal gland. If I started from here, guys, what exactly it is? What was the nucleus supplying the lacrimal gland? If you remember, the nucleus supplying the lacrimal gland was which nucleus? This is superior salivatory nucleus. So from the superior salivatory nucleus, it goes into the facial, from the facial into greater petrosal, from greater petrosal into pterygopalatine ganglion, relay over there, maxillary, zygomaticotemporal, and then into lacrimal, and finally into the lacrimal gland. So this whole thing is the secretomotor pathway of lacrimal gland. On the other hand, deep petrosal nerve is already a postganglionic sympathetic nerve. It has nothing to do with the pterygopalatine ganglion. So it simply goes inside, and without doing anything, it comes outside. Deep petrosal nerve, supplying the same region which are supplied by this nerve here. It also supplies into the nasal cavity, but this is a deep petrosal nerve, is postganglionic nerve, so it has nothing to do inside the ganglion. It simply passes through the ganglion without relaying in. So this is one part of facial nerve, this is one section of facial nerve, and we are done with the pterygopalatal ganglion completely, topographically as well as functionally. Coming inside the medullary cavity, facial nerve in the medullary cavity from the posterior wall supplies this muscle that is stapedius. Stapedius muscle is supplied by the facial nerve from the posterior wall, and it gives off a branch which actually has nothing to do with the medullary cavity and comes out related very close to the medial surface of the tympanic membrane, called as cauda tympani nerve. This is cauda tympani. What we already know about cauda tympani is that cauda tympani nerve, it joins the lingual nerve, and what we know about lingual nerve, that lingual nerve is topographically related to what ganglion? That is submandibular ganglion. So guys, this is the, let's say this is lingual nerve here, this is lingual nerve. Which is topographically related to submandibular ganglion. So cauda tympani nerve joins the lingual nerve so that it can reach the submandibular ganglion, and we know the rest of the story, that how postganglionic fiber comes out. The postganglionic fiber will be the branch of lingual nerve only. So postganglionic fiber are the branches of lingual nerve, will go and supply submandibular gland and sublingual gland. Cauda tympani is what type of nerve? Cauda tympani is also preganglionic parasympathetic nerve, and it's a mixed nerve. It is not only supplying the submandibular ganglion and sublingual gland, it is also carrying the taste sensation from the anterior two-thirds of tongue. So it is having both functions, secretomotor as well it carries the taste sensation. So cauda tympani is a mixed nerve. It also carries a taste sensation from anterior two-thirds of tongue. Taste sensation from anterior two-thirds of tongue except circumvallate papillae. Except circumvallate papillae. Guys, circumvallate papillae are developmentally, they are the part of posterior one-third. Circumvallate papillae are they develop from the hypobranchial eminence. So circumvallate papillae, they are present in anterior two-thirds of tongue, anterior two-thirds of the tongue, but they are supplied by the glossopharyngeal nerve, the nerve of the posterior one-third. So taste sensation from the anterior two-thirds of tongue except circumvallate papillae. So this is all by the cauda tympani. Carries the taste sensation. It also supplies the submandibular and the sublingual gland. So it's a mixed nerve. And whatever is done by the cauda tympani nerve, it is done with the help of lingual nerve. Again, you can say kind of hitchhike. It hitchhikes the lingual nerve to reach the submandibular ganglion, and the postganglionic fiber are the branches of the lingual nerve only. Well, this is about the two glands supply here. We have the submandibular and sublingual gland. This is the submandibular gland, sublingual gland, and that is lacrimal gland. Once the facial nerve comes out of the stylomastoid foramen, the facial nerve that we know goes to the parotid gland and divides into 5 terminal branches or 5 motor branches. Basically nothing, it is not going through the parotid gland, it is going through a plane which is present between the superficial and deep part of parotid gland. We call it Pate's fasciovenous plane. So there is a plane called as Pate's fasciovenous plane. This is a plane of surgical importance when you have to divide the parotid gland. The incision goes through the Pate's plane, Pate's fasciovenous plane. It is having the facial nerve and all the retromandibular vein which are present in the region of parotid. So Pate's fasciovenous plane through which the facial nerve goes between the superficial and deep part of parotid and divide into these 5 terminal branches. The 5 terminal branches which nobody is going to ask you, because that's not the type of PG question they ask, that what muscles are supplied by the facial nerve. So branches are temporal, zygomatic, buccal nerve, upper and lower buccal. Remember we said there's a buccal branch of mandibular nerve which is supplying the skin of the cheek and mucosa of the cheek. This is buccal branch of facial nerve. It's a motor nerve. It supplies buccinator muscle. So we have buccal nerve, then we have marginal mandibular nerve, and finally cervical nerve or cervical branch. This is one which we need to remember because you will find the cervical nerve also present in the roof of the posterior triangle. So cervical nerve which supplies the subcutaneous muscle present in the neck, that is platysma. So out of all these branches, at least remember the cervical nerve which supplies the platysma muscle. So facial nerve goes in, divides into these 5 branches in the vicinity of the parotid gland, comes out and supply all the muscles of facial expression, out of which the cervical branch is supplying the muscle, that is platysma. Well, a branch of facial nerve also goes posteriorly and it supplies certain muscle in this region, and these are the muscles which they do ask in the exam. The facial nerve, when it goes posteriorly, guys, see what muscle, there are 4 muscles that we need to remember supplied by facial nerve here. We already said that mandibular nerve supplies 2 muscle in the floor of the mouth by the branch called as inferior alveolar nerve. So the inferior alveolar nerve, before it goes inside the mandible, it gives off nerve to mylohyoid, which supplies mylohyoid and anterior belly of digastric. So anterior belly of digastric is supplied, that is by mandibular nerve. Now comes the posterior belly of digastric. Posterior belly of digastric and the muscle, I should say the best friend of posterior belly of digastric, the stylohyoid. These 2 muscles are running together, they are present in the same triangle, making the boundary of the same triangle. Developmentally they are the same, having the same nerve supply, even insertion is more or less the same only. So the posterior belly of digastric and stylohyoid muscle, these 2. Then we have few rudimentary muscle present around the auricle. Now few of us can move our auricle without touching them, so these are called as auricular muscles. And one muscle of facial expression, guys, which is spanning in this region. So we have fronto-occipitalis. Fronto-occipitalis, we are talking about which belly now? Occipital belly or occipitalis. I repeat the name again, posterior belly of digastric, stylohyoid, auricular muscle and occipitalis. They are the one which are supplied by this posterior division here, and these are the important one to remember. Posterior belly of digastric, stylohyoid, auricular muscles, specifically superior and posterior, and occipitalis. Now these are the 4 very important muscles which you need to remember, supplied by the facial nerve by passing behind the when coming out of the stylomastoid foramen. So a main nerve trunk, it goes into the parotid gland, supply all these muscle, and this branch, also called as the posterior auricular branch, supply the posterior belly of digastric, stylohyoid, auricular muscle and occipitalis. So well, this is about the facial nerve, the important thing about facial nerve. And in the facial nerve we are done with 2 ganglions functionally as well. One is pterygopalatine and one is submandibular ganglion. So it is forming a secretomotor pathway for the lacrimal gland. It is forming a secretomotor pathway for submandibular sublingual gland. It is carrying the taste sensation from the anterior 2/3 of tongue. It is supplying a muscle in the middle ear, that is stapedius, and it supplies certain muscles present behind the auricle or in the neck as well. Now based on this supply, if I come back to the cranial of columns, guys, how many columns do we have for facial nerve? Actually facial nerve, when gives off this posterior auricular branch, it also supplies the skin behind the auricle, or some part of the skin behind the auricle is also supplied by facial nerve. So based on the function, now look at this, it is supplying gland, it is supplying submandibular sublingual gland, it supplies lacrimal gland. Glands in smooth muscle are supplied, are in which column, guys? We said GVE column, general visceral efferent column. General visceral efferent column is for smooth muscles and glands, and facial nerve is definitely supplying glands. So one column for facial is GVE. Facial nerve supplies muscles of facial expression, and we said muscles of facial expression, muscles of mastication, facial expression, palate, pharynx and larynx, all these are pharyngeal arch muscle. Pharyngeal arch column, what was the pharyngeal arch column? That is SVE, special visceral efferent, because of all the pharyngeal arch muscle, facial muscle, the SVE column. Facial nerve carries taste sensation from the anterior two-thirds of tongue. What was the nucleus for the taste sensation? The nucleus for the taste sensation was nucleus of tractus solitarius, and nucleus of tractus solitarius was in which column? It was in GVA and SVA column, but we are talking about only taste, not the general sensation. So we are not considering GVA, we are considering only SVA, special visceral afferent. Special visceral afferent. Facial nerve apart from this is also supplying the skin behind the auricle, and we said the skin, all the skin from the face or from wherever it is supplying, if it is supplying the skin or the somatic structure, it will go into which column? GSA column, the trigeminal nuclei. Say it's a trigeminal nuclei, still the facial nerve is having the column that is GSA column. It doesn't matter what is the name of the nuclei, what matters is the function. The GSA column is having trigeminal nuclei, which is responsible for carrying all the general sensation from the body wall, and sensation behind the auricle is a general sensation and obviously from the body wall, so we'll go into GSA column as well. So guys, I repeat again, GVE, SVE, SVA and GSA. Why GVE? General visceral efferent, because it supplies glands, submandibular and sublingual. SVE, muscles of facial expression. SVA, special visceral afferent, that is taste from anterior two-thirds of tongue, and GSA because it also supplies the skin. It's a mixed nerve, it also supplies the skin, a very small part of the skin behind the auricle. So these are the four functional columns for the facial nerve: GVE, SVE, SVA and GSA. Coming to the glossopharyngeal nerve, and once we are done with glossopharyngeal nerve, we are done with all the ganglions topographically as well as functionally. So let's talk about this glossopharyngeal nerve here. We'll go schematically here. So part of brainstem, as I said, we'll talk about this later on, that which part of the brainstem it is exactly coming out from. Glossopharyngeal nerve, guys, glossopharyngeal nerve comes out of the jugular foramen. See, there is something common about the glossopharyngeal and vagus nerve. The common thing about glossopharyngeal nerve and vagus nerve is both will begin from the same part of the brainstem. They both even share a same motor nuclei. They both come from the nucleus ambiguous. They both come out of the jugular foramen, and they both supply the bifurcation of common carotid artery, that is carotid body and carotid sinus. So let's say if this is the bifurcation of common carotid artery here, so we have carotid body and carotid sinus, the chemo and the baroreceptors respectively. The glossopharyngeal nerve it supplies carotid body and carotid sinus. It takes the sensation from the carotid body and carotid sinus, and this nerve is called as carotid nerve, also called as nerve of Herring. This is also called as nerve of Herring, a branch of glossopharyngeal nerve supplying carotid body and sinus, called as nerve of Herring. The glossopharyngeal nerve, this is common carotid artery. The glossopharyngeal nerve it gives off a branch which goes into the medullary cavity. You guys talk about this branch a lot in ENT. This is a branch which is called as Jacobson's nerve. We call it Jacobson's nerve, or you can call it tympanic branch. It goes inside the medullary cavity, the Jacobson's nerve. In the medullary cavity, on the medial wall of medullary cavity, there is this promontory. So promontory is on the medial wall of medullary cavity. So it reaches this promontory and it participates in this plexus, that is tympanic plexus. It participates in tympanic plexus. Well, that's not the only nerve in the plexus. When you say plexus, it is also having sympathetic component as well. Carotico-tympanic nerve will also come to it. But let's just only talk about this Jacobson's nerve. The Jacobson's nerve contribute to tympanic plexus. One resultant nerve which is coming out of the tympanic plexus, this nerve is called as lesser petrosal nerve. See, that completes petrosal nerves. We are already done with greater petrosal, deep petrosal. This is now about lesser petrosal nerve. And once again, lesser petrosal nerve, what do you call it? It is preganglionic or postganglionic? It is preganglionic. We still can't see any of the parasympathetic ganglion. It's a preganglionic nerve. And because it's a branch of glossopharyngeal nerve, it is a parasympathetic nerve. So it is a preganglionic parasympathetic nerve, the lesser petrosal nerve. This lesser petrosal nerve comes out through which foramen? Once again, the mnemonic, foramen ovale for male, M-A-L-E. So L is for lesser petrosal nerve coming out of foramen ovale, isn't it? This is M-A-L-E, the structures coming out of the foramen ovale. We are already done with M, that is mandibular nerve, and now we are talking about L, that is lesser petrosal nerve. And lesser petrosal nerve comes out of the foramen ovale. If you remember, foramen ovale is a superior relation of which ganglion? That is otic ganglion. So it will go and relay into the otic ganglion. Postganglionic fibers from the otic ganglion will go and supply this parotid gland. The question is, what nerve is this? Now you need to work out on this. You tell me, what nerve is this? The nerve which comes out of the otic ganglion and supplies this parotid gland. Zoom out. See, the nerve which comes out of the otic ganglion and supply the parotid gland. Now what was the feature, guys? We said the nerve which topographically connects the ganglion carry the postganglionic fiber. Otic ganglion is topographically related to what nerve? It is related to the trunk of mandibular nerve. So you can say, or simply mandibular nerve. So which branch of mandibular nerve is going in supplying the parotid gland? If you remember, posterior division of mandibular nerve, we have three branches, ALI, A-L-I, auriculotemporal nerve. Remember, auriculotemporal nerve was the one which was supplying the parotid gland and TMJ. So this postganglionic fiber, they will come through mandibular nerve and through auriculotemporal nerve. Postganglionic fibers will come out through auriculotemporal nerve. So this is the secretomotor pathway of parotid gland. It all starts into the nucleus, and the nucleus is, this time the nucleus is inferior salivatory. From the inferior salivatory nucleus to the glossopharyngeal nerve, to the Jacobson's nerve, tympanic plexus, lesser petrosal nerve, otic ganglion, relay into the otic ganglion, and the postganglionic fiber is by auriculotemporal nerve which supply parotid gland. Another thing about the glossopharyngeal nerve is it supplies only one muscle. There is only one muscle which is supplied by the glossopharyngeal nerve, and that is stylopharyngeus. The only longitudinal muscle of pharynx which is supplied by the glossopharyngeal nerve is stylopharyngeus. And then finally the glossopharyngeal nerve also supply posterior 1/3 of tongue along with circumvallate papillae, and it's not only the posterior 1/3 of tongue and circumvallate papillae, guys, it supplies the posterior 1/3 of tongue, that is posterior 1/3 of tongue plus these circumvallate papillae. And if you go with the side, I mean, what is there on the side of posterior 1/3 of tongue? We have palatine tonsil, and then above we go, we have soft palate. So even palatine tonsil and soft palate, that region is also supplied by the glossopharyngeal nerve. So I would say that it carries general sensation and taste. It is carrying both general sensation and taste from posterior 1/3 of tongue, circumvallate papillae, palatine tonsil, and soft palate. although the majority of the taste buds which are present in the soft palate, they are not going through the glossopharyngeal nerve. They will go through the lesser palatine nerve into the facial nerve. Lesser palatine nerve and then into the facial nerve. So soft palate, mainly general sensation from the soft palate mainly is by the glossopharyngeal nerve, but it carries the general and taste sensation from posterior 1/3 of tongue, circumvallate papillae, palatine tonsil, and mainly the general sensation from the soft palate. Now looking at all this, looking at this supply of this glossopharyngeal nerve, now what are the columns? Once again, what are the cranial nerve columns for that? Now let's highlight the features here, guys. It is supplying the gland, parotid gland, that is one column. It supplies one muscle of pharyngeal arch, two column. It carries general sensation and taste sensation, four column, and it is also believed that the glossopharyngeal nerve carries proprioception from the stylopharyngeus. That makes it 5 column. So there are 5 column for glossopharyngeal nerve. What are the 5 columns? Let me start from there. It supplies a gland, parotid gland. So the column is, gland are supplied by GVE column, general visceral efferent column. It supplies parotid gland. It supplies one muscle of the pharynx, stylopharyngeus, and also carry proprioception from this. Supplying the stylopharyngeus muscle, that is SVE, branchial arches column is SVE, special visceral efferent, supplies stylopharyngeus. Also carrying proprioception. What is the nuclei for proprioception, guys? The nuclei for proprioception is mesencephalic, and mesencephalic is in GSA column, general somatic afferent. If I can rub this part here. General somatic afferent, stylopharyngeus proprioception. General sensation and taste sensation from the viscera, GVA and SVA. GVA and SVA. General sensation and taste sensation from the viscera, obviously. So we have 5 column for the glossopharyngeal nerve. GVE because it supplies parotid gland, GVE, that is general visceral efferent, SVE because it carries it supplies the stylopharyngeus muscle and also carry proprioception from it, so GSA as well. GVA, general sensation from all these and taste sensation from all these, so GVA and SVA. So we have 5 column. The easier way to, for MCQ point of view, the easier way to remember, except first column and the last column. What was the first column? GSE. And what is the last column? SSA. So except GSE and SSA, everything is related to the glossopharyngeal nerve. First was GSE, general somatic efferent. So except general somatic efferent and special somatic afferent, all columns are related to glossopharyngeal nerve. Now with this glossopharyngeal nerve, we are done with all 4 ganglions topographically and functionally. So let's do one thing, let's make a summary column for summary chart for all these parasympathetic ganglion, and then we will move on to the next nerve. So let's summarize all these parasympathetic ganglions. So do one thing, just make 3 column here. One is topographic, the ganglion, topographic nerve and functional nerve. Topographic nerve and functional nerve. So let's begin with the ciliary ganglion first. Ciliary ganglion, guys, tell me, Ciliary ganglion is topographically related to what ganglion? What is the topographic ganglion for ciliary, topographic nerve for ciliary ganglion? The topographic nerve was nasociliary nerve. So it is topographically related to nasociliary nerve, which is branch of ophthalmic. And what was the functional nerve? What was the nerve which will come and relay into the, from the Edinger Westphal, it will come and relay into the ciliary ganglion, and that was oculomotor. So oculomotor nerve is the functional nerve. Topographic is nasociliary, branch of ophthalmic, and functional is oculomotor. Next we have pterygopalatine ganglion. Pterygopalatine ganglion, topographically it was hanging to maxillary. It was topographically related to maxillary nerve, and functionally it was greater petrosal nerve, branch of facial nerve, which is relaying into it. Greater petrosal nerve, that is facial nerve branch, which was functionally related to pterygopalatine ganglion. Submandibular ganglion, topographically to the lingual nerve. Remember, it is hanging to the lingual nerve, that is branch of mandibular, and functionally lesser petrosal nerve. Functionally chora tympani nerve. Chora tympani branch of facial nerve. So you can see facial nerve is making functional connection to two ganglions. One is pterygopalatine and to the submandibular. And lastly we have otic ganglion. Topographically otic ganglion is related to mandibular nerve, precisely to the trunk of mandibular nerve. And functionally it is lesser petrosal nerve, the branch of glossopharyngeal. So this is all we discussed till now about the ganglions, their topographic connection and functional connection. As you can see, the topographic nerve, they are all branches of trigeminal nerve: ophthalmic, maxillary, mandibular, mandibular. Moving on, let's now go to the next nerve, and that is vagus. We'll talk about the vestibulocochlear nerve in neuroanatomy tomorrow. So let's talk about the vagus nerve. Now guys, I have this question in my mind. We said we have 4 nerves which are parasympathetic, that is 3, 7, 9 and 10. And we already saw in the summary of the ganglion, the 3rd nerve, 7th nerve and 9th nerve, they are all functionally related to the ganglion. But vagus nerve is not related to any of these ganglion, but vagus nerve is still a parasympathetic nerve. So where is the ganglion for vagus nerve? Actually vagus nerve is forming a very long preganglionic parasympathetic fiber. This very long preganglionic parasympathetic nerve, it goes, and the ganglion which are related to the vagus nerve are present in the wall of the viscera only. So vagus nerve will go and it will relay into the ganglion which are present in the wall of the viscera, in the wall of the GIT, let's say stomach, and from there only we have the postganglionic, a very short postganglionic fibers coming out there and supplying the smooth muscles and mucosal gland present in that region. So parasympathetic nerve, that vagus nerve, is a very long, preganglionic parasympathetic fiber. Their ganglion are present in the wall of the viscera. Okay. Vagus, as the name suggests, vagus, the vagus is, the literal meaning of vagus is wandering. It's a nerve with a very long, it's a longest cranial nerve. We said longest intracranial, intradural, intraosseous. Now this is the longest cranial nerve when you say. Vagus nerve, as I said, there is something common about vagus nerve and glossopharyngeal nerve. Vagus nerve coming out of some part of brainstem, let's not bother about it. Vagus nerve also comes out of the jugular foramen, and this is also going to supply the carotid body and sinus. So till here it is almost absolutely the same, just like glossopharyngeal. Comes out of jugular foramen, supplies the carotid body and carotid sinus. Vagus nerve gives off a branch, this is called as superior laryngeal nerve. A branch of the vagus nerve, this is called as superior laryngeal nerve. Guys, now if you remember, we said cranial accessory nerve supplies muscles of palate and pharynx, but not directly, it supplies it via vagus. Cranial accessory nerve, what cranial accessory will do, cranial accessory nerve will come out of the cranial cavity and it joins with the vagus nerve. And then with the vagus only, it contributes to the pharyngeal plexus. It contributes to pharyngeal plexus. Pharyngeal plexus, vague term, it's a vague term for this pharyngeal plexus. It's a plexus present around the middle constrictor muscle, having contribution from the glossopharyngeal nerve, from the vagus nerve, sympathetic nerves as well, and it supplies, the pharyngeal plexus supplies the muscles of palate, it supplies muscles of palate except the one which we already supplied by the mandibular nerve. Now what is the muscle of palate supplied by the mandibular nerve? The tensor muscle. Remember, both the tensors are supplied by mandibular nerve. So muscles of palate except tensor veli palatini and muscles of pharynx, except the one which is supplied by the glossopharyngeal nerve, that is stylopharyngeus. Muscles, stylopharyngeus is supplied by what nerve? That is glossopharyngeal nerve. Muscles of pharynx except stylopharyngeus and cricopharyngeus. You know cricopharyngeus reminds you of Killian's dehiscence. Cricopharyngeus is a part of inferior constrictor. We have two parts, thyropharyngeus and cricopharyngeus. Cricopharyngeus is supplied by recurrent laryngeal nerve, which we will see. So it is by recurrent laryngeal nerve and stylopharyngeus is by the glossopharyngeal nerve. So pharyngeal plexus here is supplying the muscles of palate except tensor veli palatini, and it supplies the muscles of pharynx except stylopharyngeus and cricopharyngeus. And all these structures, all these muscles are supplied by the cranial accessory via vagus. So I can say they are supplied by VAC, they are supplied by vago accessory complex. They are supplied by vago accessory complex. To talk more about this superior laryngeal nerve, now I need to look into the midline structures here, guys. If let's say this is the hyoid bone here, there is a thyroid cartilage, and let's say this is cricoid cartilage. Just roughly this is hyoid, thyroid and cricoid. The membrane which is present between them, this is thyrohyoid membrane. And this, the only intrinsic muscle of larynx present outside, that is cricothyroid. This is thyrohyoid membrane, and this muscle here is cricothyroid. Cricothyroid muscle. Now look at this. The superior laryngeal nerve will go and divide into external laryngeal and internal laryngeal. As the name suggests, external laryngeal nerve. Now the only muscle which is present externally here is cricothyroid. So a branch of superior laryngeal nerve which supplies cricothyroid, this is called as external laryngeal nerve. And the branch of superior laryngeal nerve which will pierce the thyrohyoid membrane to go inside and supply the mucosa of the larynx above vocal cord, because it has to go inside, it has to pierce the thyrohyoid membrane, and this is called as internal laryngeal nerve. So superior laryngeal nerve It divides into external laryngeal and internal laryngeal. External laryngeal supplies cricothyroid muscle, and internal laryngeal nerve goes inside, and this internal laryngeal nerve will supply mucosa of larynx above vocal cord. Supplies mucosa of larynx above vocal cord. Now there is an important relation of this external laryngeal nerve with the artery, that is superior thyroid artery. Superior thyroid artery. It is related to external laryngeal nerve. In thyroid surgery, see in first year what we read about all this thyroid surgery, that the ligation of the superior thyroid artery should be done close to the gland, and ligation of the inferior thyroid artery is done away from the gland to save the external laryngeal nerve and recurrent laryngeal nerve respectively. But clinically we know that both the ligations are done close to the gland only. The ligation of superior thyroid artery is done close to the gland, and even for the inferior thyroid artery which is related to the recurrent laryngeal nerve, it is also done close to the gland only and not away from the gland. Why? Because if we ligate the artery away from the gland, then we will compromise the blood supply to the parathyroid gland, which we can't afford to do. So this thing that we read in first year, that the ligation one is close to and one is away from the gland, surgically it is not correct. Both the ligations are done close to the gland only, so that the blood supply to the parathyroid gland is not compromised. Finally, there is a branch of vagus nerve which will loop below arch of aorta on the left side and right subclavian artery on the right side. Obviously this is the, let's say this is arch of aorta. This nerve which loops below the arch of aorta, this is called as a recurrent laryngeal nerve. Recurrent laryngeal nerve, as I said, it is looping below the arch of aorta on the left side and on below the subclavian artery on the right side. And why this difference, we'll talk about that in the embryology, why you see this difference on the right and the left side. So this recurrent laryngeal nerve is going to supply what? Now first see what is already supplied. We already supplied the mucosa above the vocal cord, so we still have to supply the mucosa below the vocal cord, and it's only one muscle which we all supplied by the external laryngeal nerve. So we still have to supply all rest of the muscles of the larynx. That's why recurrent laryngeal nerve will supply all muscles of larynx except cricothyroid, which already supplied. It supplies mucosa of larynx, mucosa where? Below vocal cords, plus it also supplies which part of inferior constrictor, that is cricopharyngeus. It supplies cricopharyngeus part of inferior constrictor. IC is for inferior constrictor. Cricopharyngeus part of inferior constrictor. So this is about the vagus nerve in the head and neck region. We'll talk about the vagus nerve more in the thorax, about when the cardiac plexus, and in the abdomen later on when we'll talk about the celiac plexus and all, how vagus nerve is contributing to them. So because our topic is head and neck for now, so let's stick to this portion only. So that is vagus nerve, which is contributing to pharyngeal plexus, which is basically VAC, vago accessory complex, supplying all those structures. Internal laryngeal nerve supplying the mucosa above vocal cord. External laryngeal nerve supplying only one muscle, that is cricothyroid, and whatever is not supplied by the superior laryngeal nerve will be done by recurrent laryngeal, that is all muscles except cricothyroid and the mucosa below the vocal cords. Next we have accessory nerve. Next in the line is accessory nerve. Now the first thing in accessory, guys, we know we have two parts of accessory nerve. We have cranial accessory nerve and we have spinal accessory nerve. Cranial accessory nerve makes sense. I mean, it's a cranial nerve coming out of cranial cavity from the nucleus ambiguous, so we call it cranial accessory. But why spinal accessory is called as spinal accessory? I mean, what is spinal about it? We call it spinal accessory nerve because it actually is coming out of the spinal cord. There is a spinal root value for the spinal accessory nerve. Just to schematically represent it, if this is the accessory nerve here. Now let us say this is the brain stem and spinal cord. Now from nucleus ambiguous, if this is nucleus ambiguous here, from the nucleus ambiguous, the nerve which is coming out of the jugular foramen this is cranial accessory nerve, and we know the cranial accessory nerve joins with which one? It joins with the vagus nerve. The cranial accessory nerve it will join this with this vagus nerve, and together they will form the VAC, that is vago accessory complex, which we already talked about. What vago accessory complex will supply? The muscles of palate and pharynx mainly. This is cranial accessory. What is spinal accessory? Spinal accessory nerve. Now let's say this is foramen magnum here. Spinal accessory nerve begins from the root value C1, C2, C3, C4 and C5. These cervical spinal nerve rootlets, they will form the nerve which will go back into the cranial cavity and again comes out of the jugular foramen. And that's why the name is spinal accessory. There is a spinal root value to this. This is called as spinal accessory nerve, the one which is supplying trapezius and sternocleidomastoid, the two muscles in the neck. That is about cranial accessory and spinal accessory. The one which is coming from nucleus ambiguous, the cranial accessory joins with the vagus nerve, forms vago accessory complex, which we already discussed. Spinal accessory comes from the spinal cord, from the C1 to C5 cervical spinal segment, goes back into the cranial cavity through foramen magnum and again comes out through the jugular foramen to supply sternocleidomastoid and trapezius. This is all about accessory nerve. And lastly about hypoglossal nerve. So let's also talk about the hypoglossal nerve. The hypoglossal nerve, which is a motor nerve present in the GSE column, general somatic efferent, supplying the muscles of tongue. Now hypoglossal nerve is not only about supplying the muscles of tongue. There is something more to hypoglossal nerve because it contributes to ansa cervicalis. So this is hypoglossal. Once again I am going with a schematic diagram here. If this is the brain stem, now I can say this is precisely medulla oblongata because hypoglossal nucleus is in medulla. So the hypoglossal nerve, it comes out of the hypoglossal canal and it go and supply all the muscles of tongue, all muscles of tongue except, see all these except type of questions are very important, except one muscle, and that is palatoglossus. Except palatoglossus, and makes sense. Palatoglossus, it's a muscle of palate also. It's a common muscle for palate and tongue. It's a muscle of palate as well as tongue. And we already saw that muscles of palate except tensor veli palatini are supplied by VAC. So palatoglossus is already supplied by vago accessory complex. So all the muscles of tongue are supplied by hypoglossal nerve except palatoglossus. Well, if you look at the first cervical spinal nerve C1, the C1 fiber will hitchhike with the hypoglossal nerve. As we saw, the head and neck is full of hitchhiking. So we have the C1 fibers which will go and hitchhike with the hypoglossal nerve, and in the anterior part they will supply two muscles, one above the hyoid bone and one below the hyoid bone, that is geniohyoid and thyrohyoid. Geniohyoid and thyrohyoid, and the one which you got to remember all the time is thyrohyoid. Why? Because thyrohyoid is the only strap muscle which is not supplied by ansa cervicalis. It is the only strap muscle not supplied by ansa cervicalis. Only strap muscle not supplied by ansa cervicalis. And what exactly is ansa cervicalis? Talking about the ansa cervicalis. What is ansa cervicalis, guys? See, if these are C2 and C3 root, the C2 and C3 root will unite. Now there is a descending limb which will come from C1 from the region of hypoglossal nerve, and the descending from the C2 and C3. This is called as, because it is descending from the hypoglossal region, so we call it descendens hypoglossae. Descendens hypoglossae. And this one is called as descendens cervicalis. This is called as descendens cervicalis. Descendens hypoglossae and descendens cervicalis together, they will meet in front of the carotid sheath and they form ansa cervicalis. Called as ansa cervicalis. And what is this ansa cervicalis supplying? We said the ansa cervicalis supplying all the strap muscles. Namely, from the descendens hypoglossae, we have this superior belly of omohyoid, and from this lower part of the loop, rest of the three muscles, that is inferior belly of omohyoid, sternohyoid and sternothyroid. Sternohyoid, sternothyroid, thyrohyoid and omohyoid, these are all strap muscle, and out of all these strap muscle, the smallest one, that is thyrohyoid, is not supplied by ansa cervicalis. This question is asked thrice in the PG exams, and every time the same question with same option. The question was that which of the following muscle is not supplied by ansa cervicalis. So they gave all the strap muscle including thyrohyoid. So the answer is thyrohyoid, which is supplied by C1 fibers via hypoglossal, but not by the ansa cervicalis. So this is all about the cranial nerves and cranial nerve columns. Now moving on to the next topic, let us talk about the dura mater. Let's talk about the dura mater, the dural venous sinuses, and especially the cavernous sinus in detail. Again, an important topic from head and neck, from where a lot of questions are asked, and especially from the cavernous sinus. They do ask question about the incoming channels, outgoing channels, relations of cavernous sinus, and there is very important update also in the cavernous sinus which I need to discuss with you guys. So let us talk about the cranial dura mater and dural venous sinuses. What is special about the cranial dura mater, which is not present in the spinal dura mater? The special thing about cranial dura mater is the two layers. I mean, if let's say the studio is it's a cranial cavity and I'm standing inside the cranial cavity, there is one layer of the dura mater which is along with this wall and the roof and the floor, and that is called as the endosteal layer. Just like we have periosteum on outside, this is endosteum. So we have an endosteal layer of dura mater with the bone, and there is another layer of dura mater which is more faithful to the brain. It goes along with the curvatures of the brain, like between the two cerebral hemisphere, we have a layer of dura mater which will dip inside and come out, and that is called as meningeal layer. So we have two layers of the dura mater. If it is a coronal section of the skull, so what I'm saying is we have two layers of dura mater. The one which goes along with the cranial cavity, that is the endosteal layer, and the one which goes along with the brain, that is meningeal layer. So this is the endosteal layer, and there we have meningeal layer of dura. And between the endosteal and the meningeal layer of dura mater, there are dural venous sinuses. So that's a simple definition of dural venous sinus, a sinus which is present within the dural folds. Now, dural venous sinus, if you look at this picture carefully, dural venous sinus are present either between the endosteal layer and meningeal layer of dura mater, or they are present only within the meningeal layer of dura mater. So we have some sinuses which are present only inside the meningeal. This is meningeal layer. You can see this dural venous sinus is present only in the meningeal layer of dura mater, and those sinuses are the one which are away from the bone. Like inferior sagittal, straight sinus, they are away from the bone, so they are only present in the meningeal layer. If this is the endosteal layer, meningeal layer comes like this. So meningeal layer forms a dural venous sinus here, which is between the endosteal and meningeal layer, and then this meningeal layer go down, and it is also trapping a sinus inside here. So this sinus is present away from the bone, so it is only in the meningeal layer. So please remember, we have two types of dural venous sinus, one between endosteal meningeal and one within meningeal layer. But we never have a sinus present only inside the endosteal layer. That is not possible. Endosteal layer is the one which is not going to move. It is along with the bone. The one which is making a turn, coming out and all these, that is the meningeal layer. Endosteal layer is fixed, and meningeal layer is the one which goes along with the curvatures. That's why all the dural folds are made up of meningeal layer of dura mater. And what are dural folds? The important dural folds are like falx cerebri, falx cerebelli, tentorium cerebelli, and diaphragma cellae. These are the major dural folds we have: falx cerebri, falx cerebelli, tentorium cerebelli, and diaphragma cellae. Well, diaphragma cellae is the one which is covering the pituitary fossa or sella turcica, and it is giving passage to the stalk of pituitary. And we'll be focused right now to these three folds, that is falx cerebri, cerebelli, and tentorium cerebelli. Now, if this is falx cerebri, it's a sickle shaped fold, guys. It's a sickle shaped fold. The falx cerebri is a sickle shaped fold, and posteriorly the sickle shaped fold is resting on the fold which is present transversely. Now look at me. If this is falx cerebri, there is a sickle shaped fold between the two cerebral hemisphere. Posteriorly it is resting on the fold of dura mater which is separating the occipital lobe of the cerebrum to the cerebellum. So between the cerebrum and cerebellum we call it tentorium cerebelli. It is forming a tent for the cerebellum, so we call it tentorium cerebelli. So on the tentorium we have falx cerebri. So the falx cerebri, as I said, it is resting on this tentorium which is in the horizontal plane. And from the under surface of tentorium cerebelli there is another fold which is present between the two cerebellum. This is called as falx cerebelli. I just go with the number so that I will not label it unnecessarily here. 1 is falx cerebri here, so this is 1. 2 is falx cerebelli, and 3 is tentorium. So you can correlate there. That is falx cerebri, cerebelli, and tentorium cerebelli. Between the two cerebrum, between the two cerebellum, between the cerebrum and cerebellum, that is tentorium. And there is a notch, you can see this notch here, this is called as tentorial notch, which is giving passage to the brainstem. After the brain we have the brainstem which has to go out of the foramen magnum, so this is a notch which gives passage to the brainstem called as tentorial notch. The dural folds are holding the dural venous sinus inside, so all these dural folds will have dural venous sinus. Along the upper margin and lower margin of falx cerebri, we have two dural venous sinus here. One is called as superior sagittal sinus and inferior sagittal sinus. So we have a sinus along the upper margin here. This is called as superior sagittal sinus. and there is a sinus along the lower margin here. This is called as inferior sagittal sinus. Superior sagittal sinus. This one is inferior sagittal sinus. Both superior and inferior sagittal sinus. See, direction of the blood flow is important. It is taking the blood from anterior to posterior. So the direction of the blood flow from superior and the inferior sagittal sinus, it goes posteriorly and it drains into the straight sinus. This is straight sinus. इसको थोड़ा zoom in करो. So superior sagittal sinus and inferior sagittal sinus, it goes into the straight sinus. Straight sinus actually is receiving a vein which is coming from the brain. This is called as great cerebral vein. Great cerebral vein. Great cerebral vein, also called as vein of Galen. Great cerebral vein or vein of Galen, it drains into the straight sinus, and the straight sinus is receiving the superior and the inferior sagittal. It also receives the blood coming from the occipital sinus, which is present in the falx cerebelli. So there is a sinus which is present here. This is called as occipital sinus. And then finally it is given off to the sinus running in the transverse plane. That's why we call it transverse sinus. See, look at the direction of blood flow, guys. Superior sagittal sinus and inferior sagittal sinus is taking the blood towards the straight. Occipital is taking the blood upwards. From the confluence, it is draining into the transverse sinus, and from the transverse sinus now the blood has to be thrown out of the cranial cavity, and that is done by what vein? That is internal jugular vein. So we have to form the internal jugular vein. It drains into the blood into the sinus called as sigmoid sinus, and this sigmoid sinus meets with the sinus coming from cavernous, that is called as inferior petrosal, and together they form this vein that is called as internal jugular vein. This is sigmoid sinus and this is inferior petrosal. Inferior petrosal sinus, and together the sigmoid sinus and inferior petrosal sinus, they will meet just below the jugular foramen. They will meet just below the jugular foramen and form internal jugular vein. They form the internal jugular vein. Superior sagittal, inferior sagittal to straight. Straight takes it backwards, receives from the occipital, gives it to transverse, transverse into the sigmoid, sigmoid joins with the inferior petrosal sinus just below the jugular foramen and forms the internal jugular vein. They even ask this question that what is the formative tributaries of internal jugular vein. So these are the two formative tributary, this one and this one. So make sure to write them separately, that sigmoid sinus and inferior petrosal sinus are the formative tributaries of internal jugular vein. These are the formative tributaries of internal jugular vein. Sigmoid sinus and inferior petrosal sinus are the formative tributaries of internal jugular vein. Well, this is the arrangement of the dural sinuses, mainly in the posterior cranial fossa. I mean, we have the transverse sinus, sigmoid sinus, occipital, straight. There, most of them are present in the posterior cranial fossa. The blood from the middle cranial fossa also goes into the internal jugular vein, but first of all, where the blood is collected, the blood is first collected into the cavernous sinus, the largest sinus, and then it is given off to other dural venous sinuses. So let us talk about the cavernous sinus. Let's talk about what are the tributaries coming inside cavernous sinus and how cavernous sinus is draining the blood out. So we'll now talk about the incoming and outgoing channels of cavernous sinus, and for that let me just give you the orientation of this, what we are going to draw here. Right now what we see is like this, we have falx cerebri, so you basically saw it from the side, so we have falx cerebri and tentorium like this. Now if you take a transverse section of the cranial cavity, now what sinus is coming in this direction? What was the sinus coming like this? That was straight sinus, and the straight sinus is going into the transverse, and transverse is going into then sigmoid sinus to form internal jugular vein. Straight, transverse, sigmoid. So if you take a transverse section, make sure when you do this, start it from the bottom of your page. So we have this straight sinus, transverse and sigmoid. Just schematically, this is transverse and sigmoid. Straight sinus, transverse sinus, and this is sigmoid sinus. Okay, so there we go. If this is cavernous sinus, guys, somewhere here, let's say there is a pituitary fossa, and on the either side of the pituitary fossa, sella turcica, there we have this cavernous sinus. Cavernous sinus. The largest dural venous sinus present in the middle cranial fossa on the either side of sella turcica and body of sphenoid. Cavernous sinus, both cavernous sinus communicate to each other by this anterior intercavernous sinus and posterior intercavernous sinus. This is anterior intercavernous sinus, and this is posterior intercavernous sinus. Anterior intercavernous sinus and posterior intercavernous sinus. So they are communicating with each other. Before we talk about what are the incoming channels of cavernous sinus, first how cavernous sinus is throwing the blood out, how cavernous sinus is draining the blood out. Cavernous sinus is giving off these two sinuses, that is superior petrosal and inferior petrosal. What we already know is inferior petrosal, guys. Inferior petrosal we just saw, it meets with the sigmoid sinus to form what? To form which vein? That is internal jugular vein. This is inferior petrosal sinus. So this is inferior petrosal sinus. Whereas superior petrosal sinus from the cavernous, it drains directly into the transverse. Superior petrosal sinus, it drains directly into the transverse. That is the outgoing channel. So these are the outgoing channels of cavernous sinus, superior petrosal and inferior petrosal. The more important part is the incoming channels. The questions are more commonly are asked on the incoming channels. Now, incoming channels to the cavernous sinus, they are coming from three sources. The incoming channel, now if I take it overall like this, incoming channel to cavernous sinus is coming from three sources, that is orbit, brain, and meninges. Orbit, brain, and meninges. The question is, what are the veins coming from the orbit, from the vein, and from the meninges? The veins from the orbit which are coming into the cavernous sinus are superior ophthalmic vein, inferior ophthalmic vein, and central vein of retina. Superior ophthalmic, inferior ophthalmic, and central vein of retina. That is the contribution from the orbit. Brain, that is superficial middle cerebral vein, superficial middle cerebral vein and inferior cerebral vein, superficial middle cerebral vein and inferior cerebral vein. And the one which are coming from meninges, I mean meninges we are talking about actually dural venous sinuses draining into the cavernous sinus. There are certain dural venous sinus which drains into the cavernous sinus, that is sphenoparietal sinus and middle meningeal sinus. So these are the incoming channels, these are all incoming channels. These are all incoming channels or incoming tributaries to the cavernous sinus, that is from the orbit, from brain and from meninges. Sphenoparietal sinus and middle meningeal sinus. And guys, when we say middle meningeal sinus, we are actually talking about the anterior tributary of middle meningeal vein. It's the anterior tributary of middle meningeal vein which is referred as middle meningeal sinus. Anterior tributary of middle meningeal vein. Now there is a small catch here. If the question says incoming channels, so these are the incoming channels. We have 3 from the orbit, we have this from brain, and then we have from meninges. These are incoming channels or tributaries. But if the question says what are the outgoing channels, especially they ask this question, you know, in the PGA exam, they will ask you question which of the following are the outgoing channels of cavernous sinus. Now we will say outgoing channels of cavernous sinus are simple. One is superior petrosal, one is inferior petrosal. These are the outgoing channels. But no, outgoing channels are also called as drainage channels. Drainage channels are, one obviously is superior petrosal sinus, inferior petrosal sinus, and then this one, also superior ophthalmic vein, also superior ophthalmic vein. Now we said superior ophthalmic vein is an incoming channel. Superior ophthalmic vein is an emissary vein. It can take the blood inside to the cavernous sinus. It can also take the blood outside from the cavernous sinus. So it is in the incoming as well as outgoing channels. You know, we have some connection of the cavernous sinus to the facial vein. One is by the deep facial vein, and then one connection is by the angular vein. The angular vein here, it connects with the superior ophthalmic vein to the cavernous sinus. That's why this region is regarded as the dangerous triangle. Superior ophthalmic vein connects angular vein on the face, and inside it connects to the cavernous sinus, and it's a valveless connection. So it forms incoming channel as well as the outgoing channels. So make sure you count superior ophthalmic vein in both incoming as well as outgoing or drainage channels. So this is about the incoming and outgoing channels of the cavernous sinus. Another important thing which is asked from the cavernous sinus is about the relations of cavernous sinus. And as I said, there is a very important update, and you guys know this, that whenever you have any update for any subject, that becomes a very important question for upcoming exams. So let us talk about the relations of cavernous sinus and how exactly cavernous sinus boundaries are formed. For this we are taking a coronal section here. For this we are taking a coronal section. Now let's say this is the pituitary fossa here. These are sphenoidal, body of sphenoid and sphenoidal air sinuses. So this is the body of sphenoid and sphenoidal air sinus. This is sphenoidal sinus. Now this is a bony part here, guys. So obviously what layer of dura mater will this be? This is the endosteal layer of dura mater. This is endosteal layer of dura mater, which you will see on this bone here, that is cell on the sella turcica along with the body of sphenoid. So let's say there is pituitary gland here. This is with the pituitary gland here. And there we have meningeal layer of dura mater, which is running with the brain. Rest of the diencephalon part we have here. This is cavernous sinus. We have this cavernous sinus inside. Now first thing is how the walls of the cavernous sinus are, or what the walls of cavernous sinus are made up of. This is meningeal layer of dura mater. So we have this endosteal and the meningeal layer of dura mater. Now what you can see from this, that the lateral wall of cavernous sinus is made up of what layer? Meningeal layer. Roof is made up of meningeal layer. Floor is made up of endosteal layer, but the medial wall of cavernous sinus is made up of both. The medial wall of cavernous sinus is partly by the meningeal layer and partly by the endosteal layer of dura mater. This is about the wall. Relations. We have to talk about the relations of cavernous sinus in three parts, guys. The relations of cavernous sinus, or you can say the relations in the lateral wall of cavernous sinus, the structures which are embedded in the lateral wall of cavernous sinus, structures which are inside the cavernous sinus, and then structures which are outside the cavernous sinus. So starting with the structures within the lateral wall, and there is the update in here. Now previously we used to say there are 4 nerves which goes through the lateral wall of cavernous sinus, but according to the 41st edition of Gray's, which was released on 21st of October 2015, it says that there are 3 nerves which are present in the lateral wall of cavernous sinus and not 4, and that is 3rd, 4th and ophthalmic, and not maxillary nerve, According to the Gray's, it says maxillary nerve is present outside the layers of cavernous sinus below its level. So no more we are including this maxillary nerve in the lateral wall of cavernous sinus. Maxillary nerve is now believed that it is outside the wall of cavernous sinus, outside the walls of cavernous sinus, below the level of cavernous sinus. So these are the structures which are in the lateral wall. The structure inside the cavernous sinus is internal carotid artery, and this is abducens nerve. Internal carotid artery and abducens nerve. The structures which are inside the cavernous sinus, internal carotid artery and abducens nerve. Guys, if you ever saw this carotid angiogram, then what you will see for the carotid angiogram, the internal carotid artery goes inside. It comes out from the foramen lacerum here. It goes inside the cavernous sinus, makes a carotid siphon, and it goes above to contribute to circle of Willis. So first it goes inside the cavernous sinus, makes a carotid siphon, and it again goes above. So you will see the internal carotid artery twice, once inside the cavernous sinus, and then you will see it above the cavernous sinus. So again, when you will talk about the relations of cavernous sinus outside the wall of cavernous sinus, so one is internal carotid artery and optic chiasma. Internal carotid artery and optic chiasma. Internal carotid artery and optic chiasma are the structures present above the cavernous sinus. So these are the 3 nerves within the lateral wall of cavernous sinus. These are the 2 structures present inside the cavernous sinus. Internal carotid artery of optic chiasma are present above the cavernous sinus. And the one very important asked recently in the exam, what is the lateral relation of cavernous sinus? So just note it down. We'll talk about this in the neuroanatomy. The lateral relation of cavernous sinus is uncus. This primary olfactory area, also called as the pyriform gyrus, that is uncus. Uncus is the lateral relation of cavernous sinus. It is part of a temporal lobe separated by the rhinal sulcus, so we call it uncus. Lateral relation of cavernous sinus. So superiorly we have internal carotid artery and optic chiasma, medially we have this pituitary gland, we have sella turcica, body of sphenoidal air sinus, and laterally we have the uncus. So this is about the dural folds and dural venous sinuses. Coming on to the next topic, the one more topic that we'll discuss for today, and that is deep cervical fascia. So let's talk about the deep cervical fascia, another important topic, clinically important as well. Deep cervical fascia. Now before we go to the deep cervical fascia, guys, we should know that what are the regions in the body which are devoid of deep fascia. Now there are certain regions in the body which are devoid of deep fascia. Devoid of deep fascia. What is devoid of deep fascia? One is face. Face, there is no deep fascia on the face. The facial muscle has to originate from the bone and insert onto the skin. So there is no deep fascia. If let's say there is a deep fascia on the face, then our face will be like masked face. There is no facial expression because muscle would not be able to reach the skin. So face except parotid region. Parotid region do have a deep fascia. I mean there is an investing layer of deep cervical fascia covering the parotid gland. So parotid gland is covered in the deep fascia, but rest of the face is devoid of deep fascia. And then anterior abdominal wall. Anterior abdominal wall. The abdominal wall has to expand in case of pregnancy or ascites or obesity. The abdominal wall need to expand, and it can expand. That is an evidence of there is no deep fascia. Abdominal fascia is Scarpa's fascia and Camper's fascia, and both are superficial. There is no deep fascia in the anterior abdominal wall. Coming to the deep cervical fascia, now first let me tell you that in this 2015 November AIIMS there was a picture based question asked from the deep cervical fascia only. They gave a transverse section of the neck and asked to point out the vagus nerve in that. And it's an easy question actually. Vagus nerve is present inside the carotid sheath. So once you find out the carotid sheath, you know the answer. That is, vagus nerve is inside it. Now deep cervical fascia is having certain modifications which we need to talk about. The modifications of deep cervical fascia. And those modifications of deep cervical fascia are, we have three primary modifications called as investing layer, pretracheal layer, prevertebral layer. Investing layer, pretracheal layer, prevertebral layer. So these are the three primary modifications. And then we have modifications of modifications which are actually derived from these three only. They are also the modification of deep cervical fascia, like pharyngobasilar fascia, pharyngobasilar fascia, carotid sheath. Now they say buccopharyngeal fascia is also the modification of deep cervical fascia, but at many places it is mentioned that buccopharyngeal fascia is merely a loose areolar tissue and it is not the modification of deep cervical fascia. So I am not including the buccopharyngeal fascia in this. So buccopharyngeal fascia is a modification of loose areolar tissue. So guys, investing, pretracheal, prevertebral, pharyngobasilar and carotid sheath. So let's talk about first these three layer and then we'll switch to the rest of the fascia. So to understand this deep cervical fascia, we need to take two sections. First we'll take a transverse section and then we'll take a longitudinal section with head turned to one side to understand these fascia and their displacement. So let's first take a transverse section of the neck, and in the transverse section of neck we see how all these fascia are displaced. So let's take the transverse section first. So guys, this is the transverse section of neck. So there we go. This is the transverse section of neck. Now what are the two, let's build toward this. We don't have to draw unnecessary structures which we don't require here. Now what are the two anterolateral and posterolateral muscle in the neck we have? The anterolateral muscle here is sternocleidomastoid, and posterolaterally we have trapezius. So let's say this is sternocleidomastoid anterolaterally, and there we have trapezius muscle posterolaterally. Sternocleidomastoid, and this is trapezius. Now you tell me that which modification of, you just saw the list of modification, which modification of deep cervical fascia is this one? This is the one, this is the modification which is actually enclosing the structure, which is investing the structure. So we call it investing layer of deep cervical fascia. This is referred as investing layer. This is the investing layer of deep cervical fascia. Now let's presume we have vertebrae here. So the fascia which is enclosing all these prevertebral muscle, that is prevertebral fascia. This fascia is referred as prevertebral or prevertebral layer. Second modification, the prevertebral layer in front of the vertebrae and prevertebral muscle. And see, there is something important here, guys. Vertebrae is present here. That means all the cervical vertebrae are here, and between the cervical vertebrae we have intervertebral foramen. The intervertebral foramen which is giving passage to nerves, and the nerves which is coming out of the cervical region, they are forming the brachial plexus. That means brachial plexus will come out from here. So the brachial plexus, when it come out from here and goes into the upper limb, into the axillary region, that will be enclosed in the condensation of prevertebral fascia only. And what is that sheath called as? That is called as axillary sheath. So axillary sheath is nothing but the tubular prolongation of prevertebral fascia. So prevertebral fascia will give rise to axillary sheath. Tubular prolongation of prevertebral fascia forms axillary sheath, and there are two. The contents of axillary sheath includes brachial plexus and axillary artery. Vein is not present inside, the vein is outside. Axillary artery and brachial plexus. If you look at this vein, I mean all the fascia which we talk about, if you take the important sheath we know, the carotid sheath, the axillary sheath, the femoral sheath, all these sheaths are very kind to veins. Veins are capacitance vessels, they need to expand. In the increased venous return they will expand. If you put them inside the sheath and tightly enclosing them, they will not be able to expand. So look at this arrangement. Here the vein is outside, so no issue. We have axillary sheath and vein is present outside. Carotid sheath is having the internal jugular vein inside, but the thing is, the carotid sheath which covers the internal jugular vein is extremely thin, so it can allow the expansion of internal jugular vein. Femoral sheath, again femoral vein is inside, but medial to femoral vein we have almost a empty compartment which is only having the lymph node of Cloquet, that is femoral canal. That means again femoral vein is getting a space on its medial side for the expansion. So if a vein is, either the veins are present outside the deep fascia, that is outside the modification of deep fascia or like carotid sheath and all, or if they are present inside, then either the sheath which is covering them is thin, or you have some other mechanism so that you will provide additional space around the vein for their expansion, which we will talk about subsequently in their respective topics. So investing layer, prevertebral layer, Continue with this, guys. The next viscera that you will see in the transverse section, we have esophagus here, and let's say in front of the esophagus there we have trachea. I'm just writing T here. This is trachea. The fascia which is present in front of the trachea, the third modification, this is called as pretracheal layer. This is pretracheal layer. Pretracheal layer is enclosing what? It is enclosing the thyroid gland. It is enclosing the thyroid gland. Pretracheal fascia, it encloses the thyroid gland. So these are the three primary modifications we have: investing, prevertebral, pretracheal. In the transverse section, and yes, pretracheal layer is forming what capsule for the thyroid gland? Is it the true capsule or the false capsule? It's the false capsule. And what about the pelvic fascia around prostate? Is that the true capsule or the false capsule? That is also the false capsule. See, anything which is coming from outside is always a false capsule, whether it is coming from pelvic fascia or is it coming from this deep cervical fascia or from the peritoneal fold. These are always false capsule. What is the definition of a true capsule? A true capsule is a condensation of the stroma of gland itself, nothing from outside. It's not coming from any other fascia or peritoneal fold from outside. So this is a false capsule, and so is the prostatic fascia which is coming from pelvic fascia. Carotid sheath, where exactly is carotid sheath? Carotid sheath is present posterior lateral to the thyroid gland. So this is the region for carotid sheath here. So this is the carotid sheath. To understand this carotid sheath, let me take this out. What is there in the carotid sheath? The content of carotid sheath is common carotid artery, and what is the continuation of common carotid artery? That is internal carotid artery. These are the example of vasculogenesis. Rest of the blood vessel will come out as the branches, so we call them angiogenesis. So common carotid artery and internal carotid artery, the one which need not give any branch in the neck, there is no branch of common carotid or internal carotid inside the neck, are present inside the sheath. External carotid artery will come out because it has to give 8 branches. So external carotid artery is outside. The vein is internal jugular vein, and the nerve which is sandwiched between them is vagus. Vagus nerve, common carotid artery and internal carotid artery. It's a transverse section, so I can see only one. So common carotid artery and internal carotid artery both, along with internal jugular vein. These are the contents of carotid sheath, and as I said, the portion of the carotid sheath which covers the internal jugular vein is thinner than the which covers the artery. In the carotid sheath you see all these contents. Now first of all, how carotid sheath is formed, because we said carotid sheath is a secondary modification, it's a modification of modification. Now carotid sheath is formed by the contribution of prevertebral layer, pretracheal layer and investing layer. All three together they contribute to the formation of carotid sheath. So please remember, carotid sheath is formed by all three, that is pretracheal, prevertebral and investing layer. All three together contributes to the carotid sheath. There is an important relation of carotid sheath which we also need to remember. The anterior relation of carotid sheath is the ansa cervicalis. Guys, descendants hypoglossae and descendants cervicalis, they are adherent to the anterior wall of carotid sheath. Ansa cervicalis is the important anterior relation of carotid sheath, and the posterior relation of carotid sheath, not adherent to it, the posterior relation of carotid sheath is cervical sympathetic chain. the cervical sympathetic chain. So this is the transverse section. This was a section which was asked in the exam. There was a section given from the Netter's atlas. It was a transverse section of the neck. Many nerves were marked in it. The recurrent laryngeal nerve, which you will find in the tracheo-esophageal groove, and there was a spinal nerves which are present behind the prevertebral fascia, and few other nerves like this. They are marked on here along with the nerve inside the carotid sheath. And the question was, which of the following is a vagus nerve? So to find out the vagus nerve, you have to find out the carotid sheath, which is very easy to find. Posterior lateral to thyroid gland is carotid sheath, and in the carotid sheath, sandwiched between the common carotid and internal jugular vein, is the only nerve, and that is vagus nerve. Okay. And coming to this one more section here to understand this this deep cervical fascia, we'll take a longitudinal section. The section is taken in such a way, guys, you turn your head to one side, and if then the section is taken, so section will go from the mandible, the hyoid bone, and then we have the manubrium here. So the section is taken in the sagittal way, but the head is turned to one side. So it's a longitudinal section with the head turned to one side. So when you take a section like this, so as I said, when you take a section like this, first you will see mandible, the hyoid, and the manubrium. So we'll take the first these anterior three things which we will see in this section. So we have mandible. I'm just writing M for the mandible here, H for hyoid, and this is manubrium. The fascia which is splitting between the mandible and hyoid bone, and then continues below the hyoid bone and again split up above the manubrium. It's quite evident. I mean, the fascia which is splitting to enclose something, and if it is enclosing something, which modification of deep cervical fascia is this? That is investing layer. So when it is splitting between the hyoid and the mandible, it is splitting it is enclosing a gland here, that is submandibular gland. Make sure you label it exactly the place where I am labeling it, submandibular gland, and this is the investing layer. This is investing layer we are talking about. Above the manubrium we have this space here, this is called as burn space. The space which is trapped above the manubrium in the two layers of investing layer of deep cervical fascia is called as burn space, also called as suprasternal space. Suprasternal space. The contents of burn space are the contents of burn space. Now what do you have in this burn space, guys? First we have this is the sternal head of sternocleidomastoid. Sternal head of sternocleidomastoid, the ligament which is present between the two clavicle, that is interclavicular ligament, and both these anterior jugular vein are having a venous arch between them called as jugular venous arch. So we have the contents in the burn space are, one is jugular venous arch, sternal head of sternocleidomastoid, and interclavicular ligament. An interclavicular ligament. So this is about the investing layer in the longitudinal section. So we have you can see it is enclosing a gland, it is enclosing a space. We already saw it is enclosing two muscles, that is sternocleidomastoid and trapezius. Continuing, the next we have is the pretracheal layer. Now if this is the pretracheal layer, it extends from the hyoid bone, it encloses thyroid gland, and then it goes below and merges with the fibrous pericardium. It merges with the fibrous pericardium at sternal angle, or you can say at the lower border of T4. This is called as pretracheal layer. This is pretracheal layer, and I said the pretracheal layer is enclosing this thyroid gland inside, the false capsule of the thyroid gland. Now what we say about thyroid gland is that thyroid gland moves up along with the deglutition. Now why thyroid gland moves up with the deglutition? Because there is something holding the thyroid gland. There is a modification of this pretracheal layer which is attached to the cricoid cartilage, and once in the deglutition, when you see in the deglutition we use longitudinal muscles. The longitudinal muscles are used and all the longitudinal muscles are inserted to the posterior border of thyroid cartilage. So thyroid cartilage is pulled up, thyroid is pulled up, thyroid is connected to cricoid, cricoid is also pulled up, and cricoid is connected to the thyroid gland by the ligament called as ligament of Berry or suspensory ligament of Berry. So there is a ligament which is a modification of the pretracheal layer which is connecting it to the cricoid cartilage. Let's say this is section of thyroid. This is thyroid and this is cricoid. And this ligament here, I am making a star here, this ligament is called as ligament of Berry. So please remember, ligament of Berry is a modification of pretracheal layer. It's a modification of pretracheal layer. Now if this is the base of skull here, now let's go even back. If this is the base of skull here, and we have this, the pharynx, which will continue as esophagus. This is pharynx here. The fascia which is closely related to the pharynx is the buccopharyngeal fascia. Now we have this buccopharyngeal fascia which is closely related to it, not the modification of investing layer or the deep cervical fascia. This is buccopharyngeal fascia. This is buccopharyngeal fascia. And let's say these are the cervical vertebrae here. 1, 2, 3, 4, 5, 6, 7, T1, T2, T3 and T4. So you are looking at the vertebral column there, C1 to T4 we are looking at. From the base of the skull, from the base of the skull, from the basis sphenoid, we have this fascia extending called as prevertebral layer, and this prevertebral layer, it fuses with the anterior longitudinal ligament of T1, T2 and T3. Now there is obviously there is an anterior longitudinal ligament here. So it merges or it fuses with the anterior longitudinal ligament of T1, T2 and T3. This layer is called as prevertebral layer. This is prevertebral layer. And now you can see the two spaces here. This is space number 1 and the space number 2, although it is present between the LR fascia, which we are not drawing here. The space number 1 here, this is called as retropharyngeal space, and the space number 2 behind the prevertebral fascia is called as prevertebral space. Retropharyngeal space and prevertebral space. So this is retropharyngeal space, the space between the buccopharyngeal and the prevertebral fascia, or you can say it is between the LR fascia and the prevertebral fascia. There is another extension which goes till the T4, and between the prevertebral and vertebrae, anterior longitudinal ligament of the vertebrae, this is the prevertebral space. Now I wanted to write it down, this thing here, that this space guys, infection of the retropharyngeal space, the retropharyngeal abscess, it can easily track down into the posterior mediastinum. As you can see, there is no connection. There are few fibers, there are few septums which are going anteriorly as well from prevertebral, but that is only in the midline. So infection, or you can say the retropharyngeal abscess, it can easily track down to posterior mediastinum, whereas the prevertebral infections, they are usually present only in the cervical region. They cannot go beyond the thoracic vertebrae, T1 level. So usually you will find the prevertebral infections that are limited to cervical region, whereas retropharyngeal abscess can easily track down to posterior mediastinum going along with the esophagus, and that's why it can even cause dysphagia and dyspnea also, because trachea is also reaching from the middle mediastinum. So we have this retropharyngeal space which is extending below, and it can reach the posterior mediastinum. Retropharyngeal abscess can track down to posterior mediastinum and can cause dysphagia and dyspnea. We never have dysphagia and dyspnea because of the prevertebral infection. It is because of the retropharyngeal infections or abscess. And finally, to conclude this, let me overall write about this investing layer, guys. We are seeing this investing layer in parts. We are saying investing layer is investing two muscles. Now we are saying investing layer is investing a gland. Here we are saying it is investing a space. So what is this whole story about this investing layer? Basically, investing layer is following the rule of two. It is enclosing two glands, two muscles, two ligaments, like this. Investing layer. So as I said, rule of two. It encloses two muscles. We already saw the muscle, that is sternocleidomastoid and trapezius. It encloses two glands. We saw submandibular gland. It is also enclosing the parotid gland. It's an extension of the investing layer only, which encloses the parotid gland. Modification of investing layer forms two ligaments. The two ligaments which are also called as false ligaments of TMJ, called as stylomandibular ligament and sphenomandibular ligament. And finally, it encloses two spaces. That is burn space, and burn space is called as this suprasternal space. We also have a space above the clavicle, that is called as supraclavicular space. So there is a space above the manubrium as well as clavicle. We call it supraclavicular space. We already know what are the contents of burn space, what are the contents of supraclavicular space. We'll talk about these contents into the posterior triangle. I'm just writing it for now. That is external jugular vein and supraclavicular nerve. External jugular vein and supraclavicular nerve. We'll talk about them into the posterior triangle tomorrow, Sam. So two muscles, two glands, two ligaments, and two spaces. This is about the investing layer of deep cervical fascia. This is all about the deep cervical fascia. Well, that is all for today. We'll continue our lecture from tomorrow. You better go and revise the cranial nerves at least. This is some portion from where the maximum questions are asked from the head and neck and the neuro, I would say. So cranial nerve nuclei and cranial nerves, you better go and just revise these, and tomorrow when we'll start with the rest of the head and neck, it will become relatively very easy if you know about the cranial nerves. So we'll continue with this tomorrow 8:30. Till then, good night.